Today we are going to talk about endometriosis, and for this, our approach, what I suggest is assess, aim for what you want to do, act on it, and then count what you have done and what you have achieved for the patient. So this is how I approach patient and deal with the patient and teach how to approach our patients. So my disclaimer is there, no conflict of interest to declare. Furthermore, I would like to say all what we know currently for endometriosis is based on the natural history and characteristics of women in which it has been diagnosed. So there are a number of women who have never been diagnosed with endometriosis. And the kind of natural history and phenomena they are having, we will never know unless they are diagnosed. So our knowledge base is only on the women who have been diagnosed to have endometriosis. Now, a shared care is an approach that I always suggest, that we need to have the partnership with the patient and their family to make that decision. And these are the things I'm going to cover up here. And this is a pic of one of our building at the campus. Now, we all know that it is a pathology, a disease, a chronic debilitating disease which is present in about 10% of the women, and about 190 million women are suffering for this. So there are humongous number of groups are present who give guidance and treatment and suggestions, and patients have their own bodies to discuss matters regarding endometriosis. Now, other thing that is important is that it is a very highly variable presentation patients have. And in the 50% of the adults who are known to diagnose endometriosis say that they've been having this throughout their adolescent time period. So this starts in the adolescent time period, and our focus need to remain on the young girls who are starting their periods, and then they are presenting with pain which is slightly different than the usual, and not to disregard that pain and identify the pathology of endometriosis in them. And we'll come to that. These are the very variable sort of symptoms that appear for endometriosis, with pain, dysmenorrhea, dyschezia, dyspareunia if they are sexually active, and fatigue. Fatigue is disregarded a lot. Young girls, adolescent girls with pain and fatigue, people should think of endometriosis in them. And then we have all the other associated conditions, and among them the two bigger pathologies which exist are the adenomyosis and the uterine fibroids. So if somebody has endometriosis, they have high likelihood of having uterine fibroids as well as adenomyosis. So adenomyosis is something which we, as a resident when we were training, we would hardly see any case with adenomyosis. And now left, right and center, we encounter adenomyosis in a subtle way or in a global way or a focal way. So different forms of adenomyosis we are seeing, which is not the same disease, but a sister disease of endometriosis. Now, I'll skip the pathophysiology because the prime two things that are related for their pathophysiology are, one is the retrograde menstruation, and other is at the time of fetal development, some of the endometrial cells are said to migrate and stuck in the pouch of Douglas. And when they become adult, and these cells which got trapped in the pouch of Douglas lead to the deep infiltrating endometriosis. So a variety of endometriosis, which is DIE, is said to be starting at the time of fetal development when these cells get entrapped there. So in adolescent, the retrograde menstruation theory holds, while for the DIE, which is separate disease of endometriosis, is more related to fetal migration of cells into the pouch of Douglas. Now, on top that presentation, the diagnosis is difficult, the presentations are variable, and hence we have a classification which is also confused classification. So there are 22 classifications available at this point in time. 22 classification of endometriosis. AAGL introduced one of the, which is American Association of Laparoscopic Surgeons, introduced one of their classification few years back, and they are pulling it back now because it is not showing the sort of predictability in terms of pain as well as fertility. So currently we can say there are 3 classifications which still hold for a long time period, and they are reproductive medicine revised classification. It is the classical one, and it is said to be that this is one sort of classification we should follow and mark our patients with it, that about the disease, how much the disease is. Second one is the ASEAN one, which was introduced about 12 years back or 13 years back. It is for the group in which you are thinking that there is a deep endometriosis. So if deep endometriosis is expected, then this is to be done. So it looks at the ABC is the anterior compartment, B is the middle compartment, and C is the posterior compartment. And F means any further away disease, either in the uterus wall, in the bladder, in the intestine, or elsewhere. So classification, if deep endometriosis is expected or found, ASEAN needs to be followed along with the first one. So first one has to be followed. Second one, if the deep endometriosis is there. And the third one is the EFI. This is the ones which people who are dealing with subfertility, doing IVF, and any other kind of subfertility should follow, because this is the only classification, and I'm saying only classification, which can predict the outcome of pregnancy. So if somebody wants to see what is the predictability of conception with this disease and surgery done for this disease, this is the classification to follow. So one, initial one for everybody, ASEAN for deep endometriosis, and EFI for prediction of the fertility outcome. The best one so far, and none above 2 are not predictable to that degree. This is the only one. So this is what I've already said. Now prevention, again, no way to prevent. Now life is again bad here, that nothing is there to predict. So risk factors which are there, Mullerian anomalies, something that we cannot change. This is the nature gives us, that we cannot do anything initially. Low birth weight, obstetric care. If the obstetric care is given good, and the person remains, have a good lifestyle with good weight, average weight, they are less likely. But somebody who's a lean weight and low birth weight at birth, they are high risk of developing endometriosis. Somebody who starts early menarche. So now again, we cannot change that. You are born in a warm climate, one will have an early menopause with them. Short menstrual cycle, this is again very difficult to sort of manage, rather change. And nulliparity, this is some factor which can potentially people can control to get married at time and have children at time. So probably we can reduce that risk factor. So some of them are modifiable and some are totally non-modifiable. Okay, so red flags. If any girl 17, around 17 has these symptoms, we should seriously evaluate them for endometriosis. In terms of their fertility preservation, we need to assess their age, their years of subfertility, or the prior pregnancy, and the tubal status and ovarian. So all of these factors need to be evaluated if we are thinking in terms of fertility. So I'm going to touch base on this a little while later. Now biomarkers. There have been number of biomarkers identified, but none of them has so far up till date has been there for clinical use. So biomarkers are out at the moment. Although people are working on it, but still none of them is there for this. So we are left with imaging, ultrasound. Plain ultrasound is an okay sort of a phenomena for endometriosis. If somebody is skilled in doing it, then they can identify the disease. If they are not skilled in doing it, then they may very easily miss out. So another thing which is coming up is the saline infusion sonopodography. This is nothing more than a fancy way of putting saline in the uterine cavity, and if the tubes are open, then we are expecting that the fluid will pass into the peritoneal cavity through the tubes, and that fluid inside the peritoneal cavity will act as a medium through the window. You can identify lesions there. So it has been attempting, people are doing it for last 4-5 years. Validation is still awaited on it, but this has a potential of identifying small lesions in the pouch of Douglas and the posterior wall of the uterus and the ovaries. So this is one thing. If someone is not skilled in doing ultrasound, then we will resort to the MRI. So MRI is on a T2 image and fat suppression sequences. We will get a good information on that. So ultrasound, one, in a good hand. Saline infusion, addition to it, gives us a better result. And MRI, if the deep endometriosis is there, or a repeat surgery has been done. So in my classical practice, I don't do MRI until and unless it has been operated before or has a deep infiltrating endometriosis. For simple cases, only ultrasound sufficient in terms of identification. Now, there's an emerging concept of working diagnosis. In the young girls, you are having high suspicion of them, but you can't pinpoint it endometriosis. So in this subgroup, now people are saying that call it a probable endometriosis rather than endometriosis and treat them. Just like presumed sepsis, neonates, for neonates, terminology is used and all presumed sepsis is being treated. So this group is also a probable endometriosis and treat them, which does not mean surgically, it's a medical treatment which need to go in first. Coming to non-drug management, physiotherapy. People have attempted exercise, pacing, goal setting, and has stand alone, they don't hold a value, but they give patients a thing to latch onto, and with other therapies, it may have a benefit, but stand alone, no, not at all. CBT is another one which, if the medications are not being used, has shown promise in chronic pelvic pain and not in endometriosis. So all the studies for endometriosis, CBT have been done, has not shown a benefit, but for chronic pelvic pain, it has. So people believe that it may still be offered to women who have endometriosis and expected to have some advantage with them. Supplements, omega-3 is showing some promise, so addition of omega-3 in diet or diet which contains omega-3 may be beneficial. The studies are showing that has advantage, so incorporating this is something one can do. In terms of pharmaceutical medications, NSAIDs have not shown to give good pain relief. So people have tried all kind of painkillers which are NSAIDs, but none of them has given a significant sort of a pain, except for when there is a flare. If there is a severe flare, then a usage may be done, but you should not expect that painkillers are going to give any major advantage to them. Inverse, oral contraceptives, progestogens, GnRH and LOG, antagonists, aromatase inhibitors. Aromatase inhibitors in the ones in which the disease pain is not getting better is a subgroup in which it is a very good modality to use for pain. In progestogens, again, Dynogest is another medication which has a very good advantage if used for pain for endometriosis. And then we can have a non-hormonal one, which are tricyclic antidepressants. They are used without a strong evidence, but because they are associated, these girls are under stress and some of them are under depression, so usage of them can concurrently help them also. So usage can be considered. In terms of surgical management for pain, superficial does not need to be treated for pain. Remember, for fertility, it will give an advantage. For pain, it will not get an advantage. If somebody is looking for fertility, then superficial endometriosis and peritoneal endometriosis will help if you treat them, but not for the pain. Interestingly, for ovarian endometriosis, there is till date no RCT which says that doing ovarian cystectomy and no ovarian cystectomy, the advantage is for, maybe it's like a parachute phenomena. Nobody has tested it and nobody will test it, but ovarian cystectomy is one of the modality to relieve pain, and it's used. The disadvantage is that ovarian reserve go down. So people have attempted multiple strategies like draining, washing, irrigating, and putting Surgicel in it, which has shown to be some benefit. But overall drainage is not the modality which ideally should be used if the ovarian function is good. If the ovarian function is not good, then one can consider the drainage, otherwise no. Surgery for deep endometriosis, absolutely mandatory. You should do and clear that disease. Again, for hysterectomy and endometriosis, no RCT is there. And we assume that it will give benefit. Yes, but removal of ovaries, literature so far does not support the removal of ovaries will give them any significant advantage. So hysterectomy alone can be considered, and if the disease has been removed, oophorectomy is not an essential component of this setup procedure. In fact, with hysterectomy, and especially if it is done abdominally, there is high risk of morbidities associated, of the surgical morbidities associated with that. And with ovarian removed, cardiovascular phenomena also are affected. So for a hysterectomy, uterus removal and a good ovarian cystectomy is a preferred choice as compared to doing a TH-BSO. But tubes have to be removed. Recurrence, interestingly, is a very tricky phenomena that it can reoccur, but if you leave it as such, it can also regress. So we don't know which will regress, which will not regress. So doing a repeat surgery, if the fertility is not desired, then one should do the surgery. Agar fertility desired hai, so repeat surgery for endometriosis is not at all a good idea. And in terms of post-operative hormone therapy, yes, one can give post-operative hormone therapy, but pre-op, lingering them on is not a good idea. Unless it's a young adolescent, young girl, in which the diagnosis has not been established, and we are saying it's a working diagnosis, it's a probable diagnosis, then use medical therapy in these young girls, otherwise no. Okay, well, skip this. Okay, I have touched all this except for the medical therapy for endometriosis inhibit ovulation. So it is not a good option. So if you are trying to have a fertility, then not a good idea to use any of the medications to suppress them. So do surgery and let them have a spontaneous pregnancy, and if they are very pushed for it, start ovulation induction. So I have already verbalized this. So now, in this one, okay, coming to regardless of the pain or the fertility, if the ovarian cyst is larger than 5 centimeters, standard treatment will remain as stripping of the lining of endometrium. And remember, when we are stripping the endometrium, we should look very closely. The glossy part of the cyst wall, the thinnest part of the cyst wall need to go away. The tissue attached on it, the raw tissue which is there, pinkish structure, should not go away. The tendency is to take that pinkish tissue along with the cyst wall, and that reduces the ovarian reserve. So whenever we are doing it, try to rub it off, see how much of the glossy ovarian cyst wall is there. Take that cyst wall only, but not the pinkish tissue coming along with the cyst wall. So otherwise the ovarian reserve is going to go down. Now this is another sort of a therapy which we have also been practicing for some time, is the ethanol aspiration therapy. With a large cyst, the cysts which are big, like 8, 9, 10, 12 centimeter big, and if you do a cystectomy on them, the ovarian reserve is gone. So people have suggested to use ethanol with that. So you do a laparoscopy or ultrasound, depending upon your comfort zone. Wash it, clean it, drain it, and install ethanol in it. And after installation of ethanol, leave it for 10 minutes or something. Then wash it out, take a biopsy and come out. And put the patient on GnRH analogs and progesterone, and revisit after 3 months. After 3 months, if the everything has been sorted out, maybe. Like in our case, what we have seen, like 70% of the cases do not require any surgery, simply with this strategy. But the ones who require surgery are 30% in which we go in and do the cystectomy. And then the ovary is small, tiny ovary, and when you peel off, the tissue damage is significantly less. So this is another modified strategy which can be adopted. Now, IUI for fertility, for endometriosis, a good strategy. A good IUI will give you about 8 to 12% high notch on it. So anybody who's practicing fertility should seriously consider doing IUI because this is one notch up which is going to build your practice and will get you more patients to either to refer or to do things. So not to give away this simple strategy. And interestingly for IVF, doing surgery before ART for infertility associated with superficial peritoneal endometriosis is not at all recommended. Doing surgery for ovarian endometrioma before ART to improve live birth is not recommended. So over the years in our own practice also, we have gone down from doing everybody, operating everybody towards a restricted phenomena of doing surgery. So best is not to operate too much if somebody wants to go for subfertility treatment. And I would rather send them to an IVF center, which we don't have, to get the embryo frozen. And once they have frozen the embryos, then attempt the ovarian cystectomy on them. So it may be difficult for the person who's doing the embryo pickup, but that's the skill they need to develop over time to be able to do ovum pickups in women who have large endometriomas. But if you are going to operate on them, the ovarian reserve is going to go down. So best approach is least touch on them, refer it to colleagues who can do embryo freezing on them. They come back, you do the surgery, and then they get the embryo transfer and get on with the pregnancy. And believe me, they don't run away. These patients don't run away. They will go and get the procedure done and come back. So controversy. Also, there is a minor chance of malignancy. So whenever we are operating, always take a biopsy. And remember, biopsy is 30% it will be negative for endometriosis. But if you think clinically it is there, you treat it. Even if the biopsy says no endometriosis found, hemorrhagic tissue found, so you keep that in mind. And for specifically less than 3 centimeters of endometrioma should not be touched at all if you want any fertility in the patient. So 5 above, yes. Below 3 or 3, no. Absolutely no. Now, AMH will reduce, and AMH is a great tool to assess. So 7 months down the line, if you have done the surgery, see after 6 months, 7th month, if the ovarian reserve is good, your enteral follicle count would be good, and your AMH would be good. AMH less than 1.2, we start to worry. Less than 5, we are very worried. Going down to 0.0 or something, anywhere, it is nearly a lost cause. We'll talk about this at some other point in time, but overall, we should aim 1.2 AMH as the classical AMH, which is their enteral follicle count 7 to 8 at least there in these patients. Have them a follow-up, and this is a simple what I have already spoken about. Identify, do the ultrasound. If deep endometriosis is there, do the MRI. If pain is there, treat them for the pain, especially the adolescent one. If they are married and they want to have children, if the cyst is less than 3 centimeters, don't operate on them. If the cyst is about 5 centimeters and ovarian reserve is very good, which means above 1.2, operate on them, do a cystectomy. And if AMH is very high, again, that's bad. So large ovarian cysts like 7, 8, or 10 centimeter, send them to your IVF colleagues, tell them to do the embryo pickup, embryo freezing, come back, do the surgery, and that's the way. So assess them, aim for the patient values and desires, act on it, take actions, and achieve what you want to achieve for your patients. Thank you.